Okay, opposition. Please make way for them.
Me too.
All right, opposition, let's go.
All right. Good morning, members. Juan Thomas, representing the California Medical Association. I'm going to make a couple remarks, and then we'll turn it over to our physicians who are going to testify on the bill. Historically, CMA has strenuously opposed removal of physician supervision because for the last 40 years, the requirement for allied professionals to be under supervision has ensured a high quality of health care in California and has ensured patients and consumers that they have access to a physician. SB 323 actually offered up a different scenario for us where they were proposing that in these integrated settings that Senator Hernandez proposed that are integrated practice settings that you would remove the requirement for supervision. While we would prefer that supervision remains, our physician leadership said, all right, in these particular settings, we are okay with removing supervision provided that the consumer protection and patient safety provisions that physicians have to adhere to are also required that NPs adhere to those adhere to those requirements also. Even the Board of Registered Nursing agrees that physician supervision is the legal mechanism that allows nurse practitioners to perform procedures or services that are otherwise the practice of medicine. So if you're going to, in these integrated settings, remove physician supervision, nurse practitioners are going to be performing procedures and providing services that are the practice of medicine. So therefore, we think that all of the provisions that protect patients and protect consumers should apply, and that includes the bar in the corporate practice of medicine, which protects the autonomy of doctors, protects patients, and preserves the autonomy of physicians to make clinical decisions. In addition, there should be all the self-referral and anti-kickback requirements, and this is really important also, that there's one standard of medical care. If there is if an NP and a physician perform the same procedure, the consumer or the patient should have the expectation that the level of medical care and the quality of medical care in both those cases are the same. So we believe that there should be some kind of medical board involvement, some kind of medical board oversight when there's a determination of whether or not the standard of medical care has been appropriately applied. Also, I wanted to address that in the idea that nurse practitioners who are independent providers for Medi-Cal. In 2006, former Assemblywoman Wilma Chan introduced a bill that was signed and passed, which CMA supported, that allows for any advanced practice nurse to register as an independent provider with Medi-Cal and see Medi-Cal enrollees. They can independently bill and independently get reimbursed for seeing those patients. To date, the department tells us there are about 1,000, a little over 1,000 advanced practice nurses who have registered as independent providers for Medi-Cal. So what we would like to see, and we do appreciate the fact that Senator Hernandez has included in his bill the anti-kickback provisions, but we would like to see that the full range of patient protection and consumer protection statutes that exist in California are applied to nurse practitioners who, under this bill, would be able to diagnose, be able to do a plan of treatment. They have full prescribing authority, so they will be using drugs upon humans, which is essentially the definition of practicing medicine. So therefore, this bill for us, while we would prefer that supervision remain, this bill is about parity. And we think that if two individuals or two practitioners or two clinicians are performing the same procedures, which is the practice of medicine, that they should all be playing by the same rules and all have the same requirements to protect patients and protect consumers. And with that, I'd like to turn it over to the physicians.
Next witness.
Yeah, my name is Dr. Paul Finney. I'm a general pediatrician in the Sacramento area with just a couple months shy of 30 years practice in a large integrated group practice setting right here in Sacramento. You've already received detailed written testimony. I've heard from Juan Thomas here. So I'm just going to talk about three quick points. The first point is that despite its claims, I believe that SB 323 will do very little to alleviate the problem of access to primary care. About half of nurse practitioners, according to the New England Journal of Medicine, already do something other than primary care, whether that's specialty or other kinds of work. The remainder in California are largely concentrated in large integrated healthcare delivery systems. I worked in one of those healthcare delivery systems for almost 30 years, and I can tell you that the nurse practitioners in those systems are already very, very busy. There's nothing in 323 that will augment the productivity of NPs in those systems, which represent a large percentage of the remainder of NPs in our state that do primary care. As far as underserved areas go, you heard from Juan Thomas about the fact that NPs can already register and practice as for purposes of Medi-Cal. Well-done geographic studies have shown that in other states, NPs tend to locate their practices in areas that are almost identical with the areas that physicians locate. Now, that makes some sense because they would be subject to the same economic pressures that physicians are. And in our state, unfortunately, economic reimbursement for Medi-Cal is extremely low, bottom of the nation. This suspicion, or my belief that this bill will not do anything really to help access, is borne out in states like Arizona that have tried independent practice, and there's very little evidence in those states that have gone where this bill wants to go that it really has expanded access to primary care. So in short, on my first point, the access to care argument sounds good, but it's flimsy. And I believe a specious underpinning in trying to justify independent practice for nurse practitioners, which is and always really has been the goal of this legislation. Second point, to answer what appears to be a looming shortage of healthcare providers in our state, we don't need more independent practice. We need more effective use of highly integrated teams. A team approach to care, whether it's for chronic conditions like diabetes or if you show up in the ER with a heart attack, you want a team taking care of you, a highly integrated team making full use of available technologies. That's the only way that we're really going to effectively achieve full utilization of the education and training of all healthcare providers, which is a laudable goal. Independent practice, on the other hand, and this bill is a step in the other direction. It really doesn't do anything to help us work smarter and more efficiently in the ways and to the degree that we need to in order to address the looming provider shortage. Last point, if we are going to move in this direction and independent practice, then it's important that we do it right. Patient safety and quality of care must remain paramount, and if we're going to err, we need to err on the side of patient safety. If NPs provide medical care, which they will be doing to some degree should this legislation go forward, then they should play by the same set of rules that physicians should do. We should not have two sets of standards. California is a corporate bar state, and so our corporate bar amendment to this legislation takes notice of the fact that we live in that environment here. Don't create a state where we have two different types of standards for two different practitioners. In short, the amendments on corporate bar involvement of the MBC, the self-referral and kickback provisions, which apparently the proponents have taken, active peer review, very important, and the requirement for integrated team-based care are all very reasonable provisions which help make this bill safe for patients and will do a lot to help garner our support. So we urge you to strongly consider the amendments that we've laid out, but absent their approval, urge a no vote on the bill in its current form. Thank you.
Next witness.
Madam Chair, members, good morning. My name is Dr. Ronald Labugan. I'm a member of the California Academy of Family Physicians. I live in Brisbane, California, and I practice at San Francisco General Hospital and Trauma Center. At the hospital, I'm the medical director of the Family Health Center, which is the largest primary care clinic in San Francisco, and also the medical director of the Urgent Care Center. And in those two practices, we employ and rely on nurse practitioners as an integral part of our workforce in primary care and urgent care settings. We could not accomplish what we do at the hospital without them. They help our practice provide the access that our patients need, and they're able to work to the level of their training because they work in an integrated system with supported practice alongside physicians. And so it's for this reason that the California Academy of Family Physicians opposes this bill unless it's amended. In the bill, there are certain practice settings that are listed in order for nurse practitioners to be able to engage in independent practice. The very point of listing these special settings in the bill is to ensure that NPs are working independently alongside physicians and not in isolation. And this is definitely important if we are going to move into a situation where nurse practitioners are no longer working under standardized procedures that they establish in collaboration with physicians. With a more limited clinical training that nurse practitioners have, it's essential that they practice in group settings with physicians, which allow them to more easily refer or seek advice on more complicated cases. Currently, the language of the bill does not do that. And we believe that the bill should be amended to ensure that physicians are practicing alongside NPs engaged in independent practice. In particular, the terms such as accountable care organization, independent practice association, even health facility and group practice are too vague and to ensure that this collaborative practice would exist in an environment where NPs practice independently outside of standardized procedures. And that's because these terms can involve simply contractual arrangements and not necessarily the physical settings or the shared care of a patient population that we feel would be the best type of environment in which we can ensure that nurse practitioners are fully supported in practicing up to the level of their training in an integrated care system where we want to move, implementing team-based care. So, again, we would urge the members to vote no unless the bill is amended in this way.
Thank you.
Jody Hicks, representing the California Academy of Family Physicians, and I'll be brief. I just want to cover a couple of things. One is to be clear what current law and supervision means, because I think it has a word that we sort of think of as a physician standing over a nurse practitioner and supervising them in that fashion. And what it means to for current law today is you have to have one supervising physician for every 4 nurse practitioners, and they have to have standardized procedures and protocols. And what that means is, based on the relationship for that nurse practitioner, whether they're brand new or they've been in that practice for 20 years, those protocols can be as narrow or as broad as those 2 healthcare professionals decide. So it could be very limited based on their experience. It could be very broad based on their experience. But what we know about that, what we know about current law and what that affords is there is a required relationship with the physician. They have to have had those agreements ahead of time. There's a limitation to how many nurse practitioners that they can supervise, so it makes it clear that we're not having one physician and 20 nurse practitioners and they don't have any responsibility at all. Now, when this bill was presented, it was presented in a way, well, what about in settings, and I'm going to throw out Kaiser because I think that's one we all understand. In that setting where physicians and nurse practitioners are currently practicing together, does that protocol and supervision requirement make sense? And I think we came to a decision that maybe not. Maybe it's okay in those settings that we know they're working collaboratively together just because they are. They're all in the same setting. So we're in agreement on that in concept. What we need, though, is for those definitions to be very strict and ensure that what we're talking about in those settings is physicians really are practicing alongside nurse practitioners, and we've offered amendments to do that. And then when that happens, and it's been discussed, so I won't go over it, that there's the same rules apply. Thank you.
In opposition?
Matt Back, representing the Osteopathic Physicians and Surgeons of California, also in opposition.
Hi, Doug Chiappetta on behalf of Asm Physicians. We are the physicians in state service, county service, UC and CSU. We represent approximately 5,000 doctors. One particular concern the bill addresses is a primary care physician shortage. There's no primary care physician shortage. Yet, as we've argued repeatedly on this bill for a few years now, this would have deleterious impact on our labor workforce. Removing physician supervision is very detrimental in the public sector. Thank you. We oppose this bill.
Thank you. Name and organization only. Thank
Paula Treat on behalf of the California Academy of Eye Physicians and Surgeons, opposed.
Jennifer Smoes, Medical Board of California, in opposition.
Randall Hager, representing the California Psychiatric Association, in opposition.
Tim Shannon, representing the California Orthopedic Association, in opposition.
Tim Madden, representing the California chapter of the American College of Emergency Physicians, the California chapter of the American College of Cardiology, and the California Society of Plastic Surgeons, in opposition.
Tom Riley, CalDerm, opposed.
Bryce Doherty on behalf of the California Society of Anesthesiologists, in opposition.
Carl Brackensick on behalf of the California Society of Industrial Medicine and Surgery, the California Neurology Society, and the California Society of Physical Medicine and Rehabilitation, in opposition.
Anyone else? Concerns? Not sure? You have your mind still?
Under that category, Madam Chair, Stephanie Roberson on behalf of the California Nurses Association, representing 90,000 registered nurses, but many of you don't know we represent over 500 nurse practitioners in Kaiser and also in UC. Laser pointing on the issue of the corporate bar. The way we read it, if the corporate bar was placed on nursing, our registered nurses are directly employed by the hospital, direct employees. They don't belong to medical groups. They're not independent contractors. So if the corporate bar was placed on our nurses, we would effectively have to rebargain with the hospitals to negotiate those contracts again. So we're still in conversations with our collective bargaining agents. It's problematic for us. Again, our members are direct employees of the hospital, so it could be problematic. But other than that, we're going to be neutral on the bill. Thank you.
Thank you. Thank you, everyone. And I'm sure the committee probably does have questions, and I'm sure the author wants to also perhaps address some of the issues that have been raised. Just so I want to give the whole committee some of the background information on what's been evolving as we've looked at the bill. And that is that, and want to say that 2 years ago we did pass the nurse practitioner bill out. It got stuck in appropriations. We're here again, I think, with a more evolved version of the bill. And there have been some amendments taken. Some amendments I think the author probably wants to speak to. So why don't you make clear, first of all, which amendments you are willing to take and perhaps which ones you are not, and then I'll have some comments also, and we'll ask the committee for questions.
I'll have the sponsor of the bill perhaps respond to that.
So the bill has been amended to address two of the issues that the physicians raised. In California, we have a statute that prohibits self-referral. We call it the anti-kickback referral, right. BMP Code 650. The bill has been amended, so that will now clearly apply to nurse practitioners. There also was a desire to make sure that the existing peer review process, again, that's BMP Code 805, that also would apply to nurse practitioners who are working in hospitals. So both of those amendments have been taken and are in the bill that's before you today.
And are you willing to take any of the committee amendments? Yeah, she mentioned that.
Corporate bar. Yep.
But we had intent language that we were asking you to take. There were 3 on page 12.
Willing to take the intent language.
Or is it 2? You're willing to take the committee amendments except for the corporate bar?
That is correct.
Okay, just wanted that on the record. Just so the committee knows, the physicians did ask for more amendments. One regarded the business practices, the models that were referred to as the AOC and the IPA. Personally, I think that having those business models is the direction that we're going. In California with flexibility, I did not agree with the physicians on that amendment itself. And the medical board oversight did not agree with that amendment. You get into all kinds of trouble when you try to say the medical board is now going to be overseeing everyone as we change scopes and move forward. And I do think we are evolving as a state. And I believe that we have our boards. They're set up to deal with their own licensees, and that kind of an overlap is bad precedent as we go forward, as we know there will be scope after scope issue, and that is another amendment that I did not agree with the physicians on. However, on the issue of the corporate bar, I did feel that there was a reason to ask for that as a committee amendment. The reason for that was the transitioning out of the practice of nursing really into the practice of medicine, and this idea that if the primary care doctors who essentially with unsupervised nurse practitioners would be sharing an almost identical scope, that the same standards or rules, I don't know what the exact correct word would apply to their profession. I do want, for clarification, I'm going to allow others to speak too, there are exemptions, and in my request for the amendment for the corporate bar, we would of course have the same exemptions that doctors have today. And I'm going to ask for clarification on those, but it's charitable institutions, public hospitals, teaching hospitals, so all of our UC, they can already hire physicians, and the corporate bar does not apply. So the same would be true for our nurse practitioners as well. And there is a long list of exemptions, and I think some of them are covered in the analysis as well. But I wanted to make clear that it would be the same exemptions that would apply. And I think that, and I just want to say, with NPs, I think it's I'm glad to see this bill come forward. I do believe that over time and over their years of supervision, they've demonstrated that this is the right direction to go. However, that issue of the same level playing field and the same restrictions applying was something that I did find compelling. What is the reason for that? The reason is fundamentally consumer protection. I understand that we want to lower the cost of medical care, but consumer protection, and that's why the corporate bar exists. I know we can have a whole other discussion about whether the corporate bar should exist in California, but it does today. It does exist. So I think that would be a great discussion for us to have if that's a valid policy. I know our optometrists also have the corporate bar, so our author also has to function under that, and that's an issue we're dealing with in our committee this year, and we will be dealing next year, are the rulings about optometrists working for businesses, and does that influence their medical judgment? Would that impact the consumer? And so those are my concerns, and I just think at this point in time that it is a fair standard to apply as we move forward and move NPs out of supervision. So that's why I asked for that amendment, and I'm happy to continue the discussion as the committee has questions as well. Ms. Ching.
I just wanted to follow up on that and more asking a question for clarification. As you mentioned, the optometrists and the corporate bar, but if I remember correctly, we also approved a similar requirement earlier this year for AB 1306 regarding certified nurse midwives as well. Is that
yes?
correct?
We did actually, out of our committee on the certified nurse midwives, asked as a suggestion that they put the corporate bar in. They did that. We voted for that on the floor of the Assembly, and it is now over in the Senate. And yes, for consistency's sake, that's the other reason, thanks for reminding me, that I asked for that amendment in this bill as well. Thank you.
I just wanted to clarify. I wasn't sure if that...
Yes, that is the case. Mr. Mullen.
Thank you, Madam Chair, and thank you for your work on this issue. I know you've had extensive discussions with all the parties, as you often do on these very, very difficult issues. We shared the dais last year when a number of us voted for SB 491. I support this policy and concept. We are moving into a different era of health care with Affordable Care Act, the need for access, all of those things. We need to modernize our approaches. I get all of that. I guess my primary concern here is we passed that bill out of this committee and it died in the Appropriations Committee because there was stiff opposition to the bill. I approach this from the politics as the art of the possible approach. I'm looking for a path forward here that addresses some of those consumer protection concerns that Madam Chair talked about. It sounds like this corporate bar amendment, and I think a case can certainly be made on the fairness piece given what was done on the nurse midwives bill. I think there's a sort of a fairness and fair play argument to be made there. Sounds like that's politically unpalatable to the proponents of the bill and to the authors. And I want to thank both authors from both houses here for moving this issue and trying to find a way forward here. So my hope is that, and I don't know what this vote's going to be today, but my hope at least would be that we take some time here to find a path forward here. So I guess let me frame this in the form of a question to the authors. If this corporate bar amendment is not acceptable, is there an area of discussion here where there can be an incremental expansion that doesn't cause all of the alarm bells to ring from the medical community? Is there a path forward here where we can build some kind of consensus, or is this one of those issues where there's sort of that line in the sand on this corporate bar piece? I just want to kind of get a sense of the thought process here. If for some reason you have to take this thing back, is it even worthy of discussion? Is there area for movement here? Because I would like to see a policy become law in the state of California that actually moves us in a better direction. And that didn't happen last year. I'd like it to happen this year. But with the level of opposition that it engenders, I don't see that path right now. So I put that out for discussion.
Thank you very much for the question. Let me talk about 491 last year first, which it's two years ago, which got out of this committee on the policy without the corporate ban and without any support and the exact same opposition from the California Medical Association. The big difference was, I believe, where we got a lot of movement was from CAPG, which are the physician groups. Never was there a discussion during any of it, and it was held in appropriations. Hard reality is they had the votes, and I didn't have the votes. This time around, same thing. Through the policy committee, with the exception at the end, there was a mention of, well, we may have some amendments, and I'm a type of individual that's always looking for a path and trying to resolve this. But whether there's a path or not, I think we're still far enough apart. And as of today, I think that is the line in the sand. That's the hard reality. But so I instructed my staff, well, reach out, because I do not ever want to be, said that I'm not willing to work, as long as it's within reason. And we reached out, and we didn't get the amendments until the day before it was heard on the floor, which I didn't get to see them. It got out. And the vote count was significantly higher. So as of today, I'm not prepared to take the corporate ban for a couple of reasons. Number one, contracting. But let's talk a little bit about the corporate ban. The corporate ban is self-imposed by a particular profession. And if you look at its iterations over the history of this country, which it started back in the coal miner days when they needed to protect the independent judgment, and it's been changed dramatically from excluding HMOs, nonprofits, federally qualified health centers, teaching institutions, foundations, hospitals, county facilities. Perhaps, if we're going to have a discussion, and I'm willing to have it even with my own profession, and why don't we have it, the discussion, should we look at all corporate bans for all professions and how that's kind of becoming a barrier to health care, as opposed to putting in this legislation. I think we're drawing the attention away from the issue, and the reason why I introduced this bill in my opening remarks were, you know what, the hard reality is we have a capacity issue, we have a workforce shortage, and we have a distribution problem. And yes, I agree, Medi-Cal rates are poor. Yeah, that's why I'm going to be, hopefully, getting to look at that in special session. We're hand in hand singing Kumbaya on that particular issue, that we need to do that. But even if we were to increase rates, more physicians are going into specialty care for one reason and one reason only: reimbursement rates. Very few are going into primary care. And the hard reality is groups like CAPG and medical groups, but more in particular health insurance, are having a hard time getting network adequacy. So we need to look at innovative ways of how we're going to do it. So, let's look at the politics how I've got to look at it. If I were to take that, and I would assume they would still be opposed, and I would lose all of my support as well. So it puts me in a very difficult political situation right now. And right now, that's my line in the sand. I just can't do it. And I'm willing to lose this bill over that.